Okay, so these are some cases now for DSEK, and again, I want to show you our visualization. So this first part is where we are creating Descemet rexis, and as we go through there, we've got a Y-shaped dial there, which is the instrument to the right of your screen. We pause that just there, Shio. You can see there in both of those cross-sectional images, we can't see the instrument, but we can see a beautifully peeling Descemet membrane and endothelium. And that is something that we can see clinically because we have a nice clear red reflex, which is centered on the operating microscope and on the screen up to your left, but also particularly when we're performing these surgeries in eyes that have had a penetrating keratoplasty or in eyes which have had other pathologies such as posterior membrane dystrophies. We really want to see Descemet as opposed, for example, to stromal tears or folds. So if you keep playing that video at Shio, you can see as we go through, we're getting a very, very nice peel of Descemet membrane, which is clearly visible. So we've got a nice strip, and in DSEK, we can leave some of the Descemets present, whereas in DMEK we like to strip beyond. We like to strip beyond the border of the DMEK graft. Okay, next slide, please. There we are. We can see. You can see visually there on the screen. You can see the folds of Descemet membrane. Okay, next slide, please, Shio. And I think here we can see in the bottom slide in particular, at the left of the screen, we can see that very nicely scrolled Descemet membrane. So we can be sure both at live as we're performing the strip, but also through a 360-degree scan where we have Descemet membrane and where we don't. And when here, this really illustrates the benefit of this technology when we have a poor view. So this is a traumatized eye. The view's not so good, but with the OCT, we can see very clearly that we're getting a very nice separation of Descemet membrane. Okay, next slide, please. Okay, so in this sequence of video, we're performing the first stage of that dissection, where we want to perform a preset depth cut. Typically, we preset our vernier blades to around 550 micron depth. We don't measure, we don't pachymeter the donor cornea. We start off at 550 micron, and we can measure that live, of course, using the calipers. But more importantly, we can see very accurately as we progress the video where exactly we are with that depth. So if we're a long way off, if we've still got a lot of tissue to go, we can, if needs be, make the cut deeper, or if we start to see that we're very deep to begin with, we can make that shallow. And that's important because all corneas are different, and we never quite know the depth of the cornea we are making that incision to until we see it. So that's a key part, and we don't really want to perforate the cornea at this stage in the proceedings. Next slide, please, Shio. Excellent. Next slide, please, Shio. Okay, let's pause this here for a second. So for those people who are unfamiliar with DALK surgery, Gerrit Melez in Rotterdam described his first series of manual DALK using this technique. And this is a Pofic knife, and in the top left of your screen, you can see that after we've made our accurate depth incision, we are going to dissect down with this blade. Now, at the tip of that blade, there is a black line, and that is the reflection, which represents twice the depth between the tip of the blade and the endothelium when we are making that dissection in air. So the corneoscleral rim is in an artificial anterior chamber. That artificial anterior chamber is full of air, and that's the reflection. Now, experienced surgeons are able to dissect down following that dissection until that reflection almost disappears entirely. But it is not an easy dissection to learn, and it is very easy to perforate. Also, you will see that the length of that of the Pofic knife is quite short. So the surgeon needs to make that dissection to the required depth quite quickly, because as the tip of that blade is moving forward, of course, it's moving forward to the center of the cornea, and we want the center of that cornea to be as thin as possible. And what we don't want is a very thick wedge dissection where the beginning of the incision is quite thick, and then it thins progressively toward it. So you can see now, if we play the video, we can see that in real time, and this is a huge benefit, because as we're making that dissection down, the operating surgeon can see the reflection as they are making that dissection, but also they can see it on OCT, and they can stop that dissection at any stage live during the surgery and look at where the tip of the blade is relative to the corneal endothelium, and so we can dissect down to the correct level much faster and much more safely. Okay, next slide, please. Okay, the other end of that instrument is a lamella splitter. Any lamella splitter is fine, and the object of the exercise now is to maintain the plane that has been originally defined by the first instrument. If we can play that video, please, Shio. And then you can see in both axes, X and Y axes, the lamella splitter really defining that plane very clearly in the top going across, and in the bottom going forward as that splits the cornea in that plane. And as we go across the midline in that dissection, because we are dissecting across a curve, then we want to be sure that as that surgeon is dissecting over the curve, that they maintain the correct plane, because all dissectors, of course, will move in the straight line. And once again, you can see in that dissection very clearly that the dissection is following the curve of the cornea, so that we have an endothelial disc which is the same thickness all the way across and isn't thicker at the edges and thinner in the middle. Next slide, please, Shio. And that's a very nice example of that. And the next slide, please, Shio. Yeah, and here we're going right out. You can see the dissections completing, and we like to get right under the limbus there, so that when we punch out that donor disc, we have no issue of tags between the two layers. Again, you'll see the OCT being moved actively during the surgery, so that we can center wherever we want to during the surgery with that little green ring, and that's being positioned so that the surgeon is very free with movements. They can move the artificial anterior chamber, they can move their hands, and we're always remaining in focus, so we're not having to stop and then realign the focus each time. Okay, next slide, please, Shio. Here we can see this is the graft that one of the grafts that has been introduced, and here we can see two important aspects to this. If we look at the upper surface of the donor lenticule, and you might see that in both of those pictures. So if you look at the donor lenticule at the bottom, and then its upper surface, keep going across it there. Yeah, that upper surface there. You can see this kind of ruffled superior edge, these stromal fibers visible, and we like to call that a sunspot sign because they look like little sunspots coming off the sun. And that tells us that that's stroma. And then when we look inferiorly at the endothelial surface, we can see that that is a much smoother, hyperlucent reflection on OCT. So if we move the cursor down just a little bit, sheer that, yeah, if we look at the bottom of that lenticule there, we can see this hyperlucent, smooth, reflective image, and that tells us that we are in endothelium. So certainly with DSEK, even when we go down to very thin, this is quite a thick DSEK, so this may well have been one of our palliative DSEKs, but it's a thick DSEK, but it illustrates the point very nicely that you can tell the difference and you can tell the orientation of that graft, and that's not always easy to do for a number of factors. Next slide, please, Shio. Okay, moving on to big bubble DALK. This is a procedure, again, that can be tricky to learn, even for experienced corneal surgeons. Here we can see progression of the Fogler cannula. So this is a case that is, it's keratoconic. The cornea is very, very thin. We've begun the dissection at 200 microns, and we're pushing that cannula along, and we can see in those images, again, during the live surgery, where that cannula is in relation to the apex of the cone. Particularly if you look at the top image, you see that Fogler cannula just there, highly visible in the cornea. So we know that we are above PDL, and we've got at least some tissue between that and Descemet. Okay, on to the next slide, please. Okay, here we've taken off the anterior part of the cornea, and we've got this lovely shiny surface beneath it. You can see a little bubble in the anterior chamber, and it looks like we've got a nice PDL, but I hope it's visible to you. In this particular case, we could see air between the dissector and PDL, so we knew that we were not quite on that layer. Now that is a tricky situation to be in, because obviously we don't want to perforate PDL, and you can see on the screen that instrument is underneath tissue and above PDL being pre-Descemet layer. So that was a really, really useful appendage to this technique. We could just see, it's very difficult to see in the down the operating microscope. We can just see the odd very flat disc of bubble, but on the OCT we can see that that instrument is very clearly in a plane above PDL. Okay, next slide, please. And if we advance one, Shio, and again, and then for DMEK, again here, we can just see the graph flattening out. So we can, what we're doing there is we're moving the fluid. You can see the F mark in the microscope view at 2 o'clock on your screens at the top. So we can see that we've got the correct orientation. And then as we massage the cornea, we start to see fluid moving out. And then we've got a 360-degree scan there just to help us. So here we're massaging that fluid out and getting a nice attachment. And we can see that in two ways. You start to see clinically in the microscope view a much more clearly defined edge to the DMEK graft, a much more clearly defined F mark. But in the OCT view, we get a really nice clear view that the DMEK is well attached. Okay. Next slide, please, Shio. And again, here, you will see the same thing as we tap it out. You can see it linearly placed as we start moving the DMEK across. Thank you. Next slide, please, Shio. Oh, there we are. Yeah, we can see the DMEK being tapped out there. And then you'll start to see it appear. Perfect. Thank you.